This conference will now be
You
recorded.
will be getting a lot of cases, and being a private practitioner, you have to update yourself with the existing knowledge, because you will be treating mostly middle class or above upper middle class people who are not going to attend the government hospitals and all. So we have to update ourselves, right? I also started my career as a private practitioner only. After BMS, I started practicing as a private practitioner, and at that time I used to deal with so many cases. Rather than used to, I was forced to attend so many cases. Even in skin diseases and most of the Vata rogas, I used to prescribe Thaila and all in each and every case. I was unknown about the rationale, how, in which case we have to prescribe Thaila, or in which case we don't have to, like that. And the 70% I will get result. I used to get result, and 30% the disease will flare up because I am using Thaila in an unwanted scenario. No, so you are lucky that you are getting these types of exposure, and before going to practice itself, you will know where we have to use Thaila and where we not have to. I got the idea only after only by completing my KCPG, where I studied most of the fundamental principles and exposed to that much of cases. So now you know where you have to use Thaila and all. There is a principle behind that. In each and every skin lesion, if it is wet, you have to make it dry, and if the skin lesion is dry, you have to make it wet. So that is the principle behind that. So if it is a dry lesion, then you can use Thaila, and if it is a wet lesion, never have to. So that is the fundamental thing. Anyway, I am not going through the introduction and all. Just trying to share my screen. Am I the presenter? I'm not able to share my screen actually. The organizer, please make me the presenter. Then only I can open the screen selection. No.
സാറിന് പ്രസന്റർ ആക്കി തന്നെയാണുള്ളത്. Now you please make me the presenter. Yes, sir.
Okay. Now you may make me the presenter. Okay. There is this. Sorry.
Yes, sir, it's visible.
Okay. Okay.
So it was visible, not now. Yes, sir, it's visible.
Okay. Now you can see the presentation, right? Okay.
Yes, sir.
So the topic is clinical diagnosis and management of psoriasis. But before going to that topic, just brush up some our ideas about the skin diseases. Okay, because you are going to face so many types of skin diseases in your clinical practice. The contents of the presentation is skin diseases and outlook, Ayurvedic perspective of skin disease, diagnosis and management, and psoriasis and its Ayurvedic perspective. So directly to skin, I'm not going to say much about skin and all. Only the superficial layers of epidermis and dermis, the stratum corneum, which contains the dead cells, which is flaking off at the skin surface. The cell matures. It will take around 27 days from for the cells to mature and exfoliate. So in psoriasis, what happens is that it will mature within 4 to 5 days. So the normal cycle will be reduced to 1/4. That is happening in psoriasis. The stratum corneum is where the dead cells will be flaked off, and it will adhere at the stratum corneum. This is the first layer. In our Shastra, we know that 7 layers are told by Susruta Samhita in Susruta Samhita. Avabhasini, Lohita, like that. So Avabhasini, in Avabhasini, Sitma is told. Likewise, psoriasis also in modern medicine. This is the first layer where psoriasis sets in, like that in what was told in our Shastra also. And about Tok, it is the largest organ, as you know. 3 organs are mostly exposed to the outside environment. You know which are that organ systems or the system. 3 systems which is always exposed to outside environment. Only skin. What about the other systems? Anyone? This is mostly like an interactive class. So we are a few people only, so we can interact, right? So Tok is always exposed to outside environment. Which are the other 2 systems always interacting with the environment? Anyone?
Respiratory, sir.
Yeah, right. Chat box, there it is, comes respiratory system, and on another is digestive system, right? So that is why most of the allergies, as we know, either it may be food allergy or respiratory allergy or skin allergy, respiratory, even allergic rhinitis will be there, and the skin, so many of dermatitis, eczema happens as part of allergy. So inflammation, infections, these systems are more prone towards that, respiratory infections or skin infections or GIT problems. These are more common. So the Moolasthana of Tok is Mamsavasrodhas, and sorry, Mamsavasrodhasinte Moolasthana. It is the Moolasthana of Mamsavasrodhas and Adhisthana of Sparshanendriya. That all we know. And a few word about Dosha Gedi. So as all of us know, Dosha Gedi, Koshta to Shakha is responsible for the pathogenesis of a disease. Shakha means Rektades Tokcha, so Tok is considered as a Shakha. But in the case of epidermis, the epithelial cells are tightly packed. That means it is devoid of extracellular space. So what is the role of extracellular space? The extracellular space between the cell and the capillaries or the intravascular compartment serves as the space for exchange of metabolic products into the cells and also the waste products back from the cells. So this is the place where exchange happens, the extracellular space. So when we talk about Koshta to Shakha Gati, if abnormal things pass from the Koshta to the Shakha to the cells, then it leads to the disease. So that things also pass through the extracellular space itself. And if we want to bring back that things to the circulation, to the Koshta, then also it will happen only through the extracellular space. So in the case of skin, the epidermis, there is a little extracellular space. When it is devoid of extracellular, then what about the dosha sthiti? So there, the terminology we have to think, the tiryakstita doshas. So mostly the tiryakstita doshas is told in the perspective of kushta or skin disease. Tiryakstita means shodhana margam parityajya sthidam. It is away from the shodhana marga. What is the shodhana marga? Shodhana marga is nothing but it should happen through the extracellular space only. So if it is devoid of extracellular space, that means the doshas might be in the tiryakstita. There is no route for the expel. That is why it is difficult to treat diseases like kushta, and it needs some medium for the exchange of doshas. That medium is provided by the sneha drivyas like krida. So what is the importance of krida as a medium of medicine? So we can use medicines in many mediums. We can use it in alcohol medium, we can use it in water medium like kashayas, or we can use it in krida mediums. So what is the importance? The importance is that those medicines, those molecules present in krida, it can trespass the membranes very easily than that present in water. So if you give kashaya, the water medium will be present only in the blood and mostly in the extracellular fluid. It will not be getting into the tissues that much faster, that much easier. But if you use krida, the molecules will enter the cells very much in speed, high speed, or it is very much entering into the cells. It is very permeable. The cell membrane will be very permeable. So that is the importance of krida in kushta, where there is a little extracellular space to nourish the tissues or to bring back the doshas, anything for anything, or to delivering the drug to the site. Krida will be the medium. That is why Acharya told so many kridas in kushta chapters. This is a thing to remember. Okay, in Chirakari Rogas, where krida is used to deliver the drug immediately or in full concentration, or what we can say, the drug delivery system is much more good when it is used with the krida. So coming to reference of Togroga in Shastra, it is and the categorized into Swatantra and Paratantra. Swatantra Vyadis, as we know, skin manifestations, Kushta, Visarpa, Shutra, etc. And Paratantra means dermatological manifestation of systemic diseases. So pertaining to other system disorders, some skin changes will be happening. That is Terectapita, ecchymosis, or purpura, like that. So that only for a consideration. The causative factors, as you know, all the causative factors of diseases can be classified under Sahaja, Garbhaja, Jadaja, etc. And Sahaja Kushta is told under Sahaja Vyadis, also in Garbha, if Kabhagara diet and drugs may cause Shutra to the offspring like that. Jadaja and insect bites like Prita Grida, Kalaja, Prabhavaja. So we can categorize skin diseases under these according to the etiology. And in classification in modern sciences, you know, each and every skin disease is multifactorial. There may be genetic factor, there may be inflammatory factor, infectious factor, etc. In psoriasis, as you know, there is genetic cause, there is inflammatory pathology, as well as there is some metabolic pathologies also there. So it is multifactorial. So this is just a classification, and in the perspective of diagnosis, we used to take preliminary general history, and the history taking is the heart of case taking, and it is very important in skin disease because there is no other laboratory procedures, not much for diagnosing skin diseases. Only with in the perspective of history taking and physical examination, only we can diagnose the case. Important points: systemic disease, no diabetes, diabetic carbuncles in hepatitis. Also skin disease will be there. Use of medication, toxicity will cause epidermal necrolysis like things. Familial, atopy means allergy, allergic dermatitis and all, it will be familial. Long-term sun exposure may result in tumors and photosensitivity. Photosensitivity, that means the skin that is exposed to sun will be affected. So if it is within the shirt and clothes, if it is covered with clothes, there will not be affected, but fingers and all will be affected where skin is exposed to sun. Occupation, contact dermatitis will be there. Contact to dyes or dye making or paint, etc., or cement allergy, that all come under contact dermatitis. Geographic location, insect bites will be more common in some of the respective the geographic location. And any history of previous skin diseases, also sexual history, syphilis, gonorrhea, etc. So these all things we have to note while taking the history. Now coming to the dosha lakshana, this is very important. This is actually the core of identifying a skin disease. Can you see the slide? Characteristics, vata, pitta, and kapha, that was written in the top. The characteristics, just look at the characteristics. The varna, the color of the lesions. If it is Krishna Aruna Varna, if it is blackish or reddish black, then it will be more vata predominant. So this is how we identify the dosha predominance of a skin disease. And the treatment is just based on that dosha predominance only. So you have to carefully watch these lakshanas. Varna, Krishna Aruna, Rekta and Tamra Varna, silvery or coppery or erythematous or reddish lesions, that always point towards pitta. And Shveda Varna, that always will be kapha. Shveda Varna is a whitish color, always will be kapha. And Rupa, ill-defined margins. If it is not having definite margins, it will be mostly vata. Is told as asamavrita paryandam. That means it will be spreading without any borders and all. So it will be vata and will be dry, scaly. If it is pitta, pustules, blisters or oozing will be there. The oozing will be watery oozing mostly. And in kapha, scandy or watery oozing will be there, and it will be elevated. That is very important. Papules. The papules are elevated. Macules are not elevated. So if macular lesions are there, it will be vata only. And papular lesions will be, and papular, nodular, etc. will be kapha. So there are in sparsha, vata will be rough, pitta will be smooth, moist, and kapha, it will be a deep-seated thing. And nature of onset, vata will be mostly acute or subacute. It will occur within days or within weeks, and pitta will be almost acute and like bacterial infections, and kapha will be slowly progressing and chronic. Most of the ringworm infections and all will come under mandala kushta, will come under kapha vyadis. And about the sensation, painful mild itching will be vata, pain and burning sensation and sweda will be in pitta, and severe itching and sweda. This is the core thing that we have to remember while going to diagnose a skin disease. If this is okay, you can easily diagnose the dosha, and according to dosha only we will be preparing the treatment protocol. I hope you understood this. Now coming to some of the features, scaling, thin dry plates with extra keratinosis. Keratin is the protein that is present in the outside layer, which is the hardest protein, and extra keratinosis will be leading to scaling. This is a condition called Anybody? Condition? It is what we call ichthyosis. Ichthyosis, Malsya Shagala Sannibhavam എന്നൊക്കെ പറയുന്നു. It is ichthyosis. And this is atrophy what we used to find in older people, like a cigarette paper. It will be wrinkled, and a loss of elastin which is present in the dermis. So skin will be like a cigarette paper. Erosion, always pitta, superficial ulceration, which heals without scarring. As you know, ulcer, break in continuity of epithelium is called ulcer. If it is affecting the dermis, it will heal with a scar only. If it is in the epidermis, it will heal without scar. So if there is scarring, that is affecting the dermis. Now there is pustules in bacterial infection. This is the purpura petechae ecchymosis things, bleeding disorders. The cyst, almost kapha, nodular swelling and all, thickly rooted, deep-seated and all. It is Shveda Varna actually, whitish in color. So mostly kapha. What is the condition? Vitiligo, what we call. Now it is zoster-form lesions, herpes zoster, Vata Pitta. So there is no definite border, but it is erythematous, red color. So mostly Vata and Pitta, and it is acute onset also. Cellulitis, infection, bacterial infection. Cellulitis has a definite border. Even we can find cellulitis patients in our ward. Sometimes it occurs as an acute onset within a day. So cellulitis has definite border. Now it is plague, Vata Kapha, Asamavrata Parinam. There is no definite borders and all. It is spreading, but it is somewhat whitish in color and thick, elevated. So Kapha is there, and Vata will be there. If it is having red color, then the presence of Pitta also has to be noted. This is another called a lichen planus. Lichen, if you carefully view, it will be purple color, purplish or violet tinge will be there. So it is also a scaly lesion, Vata Kapha only, but mostly occurring in wrist region or up hands and foot. But violet color will be there, violet or purple color will be. That is the thing to differentiate. Lichenification means thickening of skin with increased skin marking and pigmentation. About viral infection, this is what? Papilloma virus. So you know what's wheals, which is present in urticaria, urticarial lesions, allergic urticaria. This is what is the condition? A name is written there. What is the condition? This is called dermatographia. Okay, dermatographia. Ah, yes. If you write something with a key or something else, after a few seconds, skin will be, the epidermal skin will be elevated and the wheals will be formed. It is also present in allergic urticaria. Annular lesion means ring-shaped lesions. The central portion will be having, it is cured, but periphery, there will be lesions. So that is called a ring-shaped. Ring means central hollowness. Nummular lesion means coin-shaped lesions. The center will be always filled. It is most often present in eczema. Now the bacterial infection, impetigo, the first case, honeycomb appearance. The second one is folliculitis. I mean, the third one is cellulitis. These are all bacterial infections. Redness will be there. Pitta will be predominant. Fungal infections, Kapha Pitta predominant will be. It will be Kapha Pitta predominant. It will be extensive, but border will be there. Erythema will be there. Itching will be there. Vata will also be there as scaling, but scaling will be much less compared to diseases like psoriasis. Always we will be getting a wrong information whether it is psoriasis or not. But in psoriasis, the scaling, the rate of scaling will be much more, will be thick, crusted. But in fungal infections, scaling will be much less. That is the thing to differentiate. And also fungal infections will be in flexural surfaces, and psoriasis will be mostly in extensor surfaces. Eczema and endogenous eczema, it is the factors will be within us. Midyahara vihara, like that. There is no external factors. So first one is atopic dermatitis. In childhood itself, IgE will be very much elevated. The second one is the seborrheic dermatitis. So these are eczema cases. Exogenous causes, dye allergy or contact allergy, external factors will be there. Often when the people use wrist watch or bangles, there also, or chain, there are the contact skin will be having scaling and all, eczema with eczema. Pathology in general, as we were taught in Kushta Chikitsa, Midyahara Viharana, Visheshana Virodhana, like that. Endogenous factors are there, exogenous factors are there. Papa karma, genetic factors will be there. And all these factors will lead to tridosha. All the kushtas are tridosha adhikya only, tridosha. But some of the doshas will be more predominant. That is the only thing. And leads to srodo dushti, sthana samshayan, tok, rekta, ambu, and mamsa, and lead to kushta. This is a general view of skin diseases in general. In Rekta Vriddhi Lakshana, most of the skin diseases are told Kushta, Visarpa, Pidaga, Vada Rekta, etc. And Rekta Dushti is happening only with the Pitta and Kapha Dushti. As you know, Pitta is Ushna and Kapha is Snigdha. Ushna plus Snigdha leads to Rekta Dushti. That is why Ushna plus Snigdha, Amla Rasa and Lavana Rasa are the most important culprits actually in Rekta Dushti. So Pitta and Kapha. Pitta plus Kapha Dushti leads to Rekta Dushti. That is the thing to remember. So Tukroga is Tridosha predominant with the Pitta Kapha mostly elevated, mostly in vitiated state. Toksara Purusha are resistant to skin diseases because they are genetically that much compatible to resist skin disease. So if anybody's tok is good, that means they are Toksara. Now the general treatment of choice is Vadadiga. As you know, I already told, if scaling is there, Sneha is the only thing we have to supply, whether externally or internally. So Sarpispanam is more important in Vadadiga, and Pittadiga, Rektamoksha and Virejana, and Kabhadiga Vamana. So these are all things are about, generally I have told about skin diseases. Drug selection. You look at this slide, it is very important. If the onset is acute, the dosha will be mostly Vata and Pitta. So Vata and Pitta consist of the Bhuda elements Vayu, Akasha, Agni and Jala. Bhudebhyo hi baram yasmat nasti chinda chikitsada. You have heard of that. Because apart from Bhuda, there is nothing in selection of medicine or selection of doshas, etc. So in Vata and Pitta, the Bhuda predominance will be Vayu and Akasha of Vata and Agni and Jala of Pitta. So how we can treat that? In Vata Pitta predominance, the only thing we can treat with is Prithvi or Prithvi Jala. Jala will be common with Agni and Prithvi. Prithvi Jala means Kapha, Agni Jala means Pitta. So we can treat with the Prithvi. So the example is Sneha Dravya and the Madhura Rasa. Krida is having both. So that is why in Vata Pitta we use Krida or Krida mediated things. Now if the onset is subacute, it will be Pitta Kapha. Subacute means within 3 weeks or 4 weeks. It will progress. So the Bhudadikya will be Pitta Agni Jala and Kapha Prithvi Jala. So Prithvi. So Agni Jala and Prithvi are the factors there. And the only thing is Vayu with which we can treat. And Vayu is present in Tikta Rasa and Kashaya Rasa, which will provide Ruksha. Because Pitta and Kapha both have Snigdha Guna, so we have to provide Ruksha Guna. We have to provide Vayu, Bhuda. So Tikta Rasa is very important. Vayu Akashayos Tikta. Vayu is made up of Vayu and Akasha. Vayu Akasha is Tikta. So Tikta Rasa Kashayas, and later stage Tikta Rasa Krida will be given. In chronic means Vada Kapha Dosha. It will take a long time to manifest, starting, then slowly progressing and manifesting, taking a long time. So in that conditions, Vayu, Prithvi, Jala, Artha, Bhuda, Vada, Vayu, Akasha, Kapha, Prithvi, Jala. So the only thing left is Agni and Jala. That means Ushna. So we use somewhat Lavana Rasa. Even in Vada Kapha Vyadis, Vada Kapha Tokurogas, we use Lavana, Uppitta Vellam, salt water for Dhara and all. So that is the principle how we select Lavana. But Lavana as such you cannot give internally, because Lavana and Amla or Varjya and Kushta I have already told Snigdha Ushna. So Lavana is not often given internally, but it can be used externally in Vada Kapha Rogas. So this is the general principle of drug selection as per Bhudadikya. Now Bahya is in the form of Pradisarana in wounds and Kshalana. Now coming to papillosquamous disorders, is a group of disorders where excessive scaling or flaking will be there. It may be due to epidermal inflammation or proliferation. Localized scaly rash. Scaly rashes, if we look at the papillosquamous disorder, scaly rashes only. If the scaly rashes are present below 6 weeks, or the onset is below 6 weeks, then it may be due to dermatophyte infection. Dermatophyte means fungus, fungal infections. Fungus need your dead cells to grow. So in ringworm infections and all, it is ringworm infection, the first picture. A ringworm infection, central healing will be there, peripheral lesion will increase. No, it will be growing like this peripherally. So centrally it will heal. So that means the dermatophytes grow, the fungus grows in the epidermis, the dead cells, and we usually use Villuadiguliga for that. Here prescribed Villuadiguliga for external application in Tulasi juice and all. So to prevent the fungal growth, we have to remove the extra water content and all. So Villuadiguliga will absorb all the water content and it will reduce the fungal infection. So in fungal infection, if it is not oozing, you can directly use Villuadiguliga. Tinea corporis, these are all names. Tinea corporis, extensive fungal infection, tongue and limb. Tinea cruris, which is happening in the groin. Tinea pedis in the feet. Manum in the hands, and fish in the face. So tinea ringworm infection or fungal infection may occur in each and every part of the body. If it is a generally skin rash present for less than 6 weeks, the fever, with the fever, if it is present, you have to look upon these things: scarlet fever, scarlatiform rashes in early childhood and all, Kawasaki syndrome. These are all just information. I'm not explaining all these things. Exfoliated remedies. These are all skin lesions with a fever. And if it is without fever, you have to look upon conditions like Psoriasis rosea. There is also scaly rash, but herald patch. It is a patch. This one is herald patch. A large patch will be there, more than 2 to 3 centimeters large. A patch followed with the small tiny patches. This is the distribution of Psoriasis rosea. In conditions with the central healing and all will be there. Acute guttate psoriasis we will be explaining later. And Psoriasis or like drug eruption, new drug. If some drugs like hydrochloroquine extensively used in COVID and all in first stages, HCQ. We use HCQ in rheumatoid arthritis also. So if new drugs are being used there, it may happen. Drug induced skin eruptions may happen. And localized skin rash present for more than 6 weeks. It may be seborrheic dermatitis. Seborrheic dermatitis most often fungal infection in the hairline. In scalp also, in the hairline, it will be present. And psoriasis is also a scaly rash more than 6 weeks. Lupus erythematosus associated with the erythema SLE will also present as scaly rash in the malar region. And pityriasis versicolor, usually called in Malayalam Temal like that. So it is also present as scaly rashes more than 6 weeks. And some other conditions are palmoplantar keratoderma, thickening of palm soles. It is a congenital acquired thing. Crusted scabies inside the fingers and all scabies. The scabies which lives in the burrows. Small burrows will be present in the fingers, between the fingers and all. And the tinea corporis, the fungal infection, ichthyosis. We have seen that dry skin. These are all more than 6 weeks. Also chronic plaque psoriasis, lichen planus. This is a case of lichen planus where purple violaceous lesions are seen. And pityriasis rubra pilaris, it is very rare disease. So these are all some of the scaly lesions. And coming to our topic, psoriasis. Psora means actually itching, itch, and iasis means a condition, actually condition of itching, that is psoriasis. As I already told, it is a multifactorial. Inflammatory process will be there, genetic predisposition will be there, autoimmune pathogenesis will be there. So what happens is that uncontrolled keratinocyte proliferation. I told skin will be proliferating much more. Actually, skin needed 27 days for a full cycle, but in this case, 4 to 5 days is only needed. So 4 times proliferation will be there. Keratinocyte this is initiated by inflammatory skin disease. Actually, it is a T cell mediated inflammation. Worldwide prevalence is only about 2%. So the thing to remember is that it is non-contagious. It will not spread. The onset is 2 types. Type 1 onset before the age of 40, especially from 16 to 22 years. Anybody, any children in the 10th class or 11th class approaching you with the skin disease, you must be differentiate the psoriasis. Okay. So we will not be hoping that in this young age psoriasis will come like that. So in the age of 15 to 16, there is a chance of a skin lesion being psoriasis. Only one lesion will be present in the scalp like that. But you have to go through all the examinations. So type 1 onset is before the age of 40, between the age 16 and 22 years, and type 2 onset is after the age of 40 in older age, almost between 50s and 60s. In the 50s and 60s, it will be occurring. That is a type 2. So what are the things that can trigger an outbreak of psoriasis? Some nidanas will be there, cuts, scrapes, or surgery, external things. Emotional stress, this is the very important one. Then some infections. So behind any autoimmune pathology, there will be an infection. Some medications. Even after COVID vaccination, some of the cases, I have dealt with some of the cases after COVID vaccination induced case. Medications including blood pressure medications, anti-malarial drugs, HCQ, lithium, antibiotics, etc. It can trigger this autoimmune process of psoriasis. Now the pathology is like this: stress, genetic causes, autoimmune reaction, and medication. Remember these things: stress, genetic causes, autoimmune reaction, and medication leads to hyperactive T cells. It's a T cell mediated inflammatory process, especially the CD4 and CD8 cells. And you need not go deep into that. Epidermal infiltration and the keratinocyte proliferation. Which one are infiltrating? Neutrophils will be infiltrating to the epidermal space. So something infiltrating means it is dosha gedi according to us. Dosha from kosha to shakha. So here neutrophils will be infiltrating. Now it leads to deregulated inflammatory process. large productions of various cytokines. Cytokines means inflammatory cascades, interferon, interleukin, etc. After inflammation, superficial blood vessel will be dilated. So if blood vessel will be dilated, more blood will be passing through the topmost layers. So that means erythema, redness will be there. Epidermal hyperplasia and improper cell maturation. This fails to release adequate lipids, which leads to flaking and scaling. So the skin is not capable enough to release adequate lipids to make it moist. So that will leads to drying, flaking, and scaling. So our aim is to supply adequate lipids, right, to prevent flaking and scaling. So this is actually the summary of psoriasis pathophysiology. Now coming to clinical classification, there are importantly there are 5 types: psoriasis vulgaris, inverse psoriasis, guttate psoriasis, pustular psoriasis, erythrodermic psoriasis. The last 2 are actually fatal. Pustular psoriasis and erythrodermic psoriasis are very much fatal, that needs urgent care actually. Erythrodermic psoriasis is an acute condition in which over 90% of total body surface is erythematous and inflamed. Just imagine your 90% of the body is erythematous and inflamed. What will you look like? So that is the condition in erythrodermic psoriasis, and mostly it will end in pneumonia, infection, and death. So it is a rare condition and also very much treatable as an emergency. So some other psoriasis are scalp psoriasis, palmoplantar psoriasis, like that, but it comes under these varieties only. So look at the picture. The first one, silvery, white silvery scales. These are all pictures of psoriasis. The area, sorry, the area where the elbow, the extensor surface of the elbow, the back, the extensor surface of the knees. So mostly plaque psoriasis, this is plaque psoriasis. Plaque psoriasis will be in extensor surfaces. So elbows, knees, back, trunk are the major areas. Plaque psoriasis or psoriasis vulgaris, it is about 80% of psoriasis. Total psoriasis is plaque psoriasis. No, it is characterized by silver colored scales. The scaling will be much more. That is the differential from fungal infections and all. Disorders of the fingernails and toenails. Nail derangements will be there. Pitting of nails will be there. And onycholysis will be also there. In scalp also scales will be present, plaques. The first picture is guttate psoriasis. Guttate psoriasis is below 1 or 2 centimeters only the lesions. In early childhood it will occur, mostly below 10 years of age. That is guttate psoriasis. The second one is pustular psoriasis. Small pustules will be present in the border of the lesions. The third one is erythema. I have already told it is fatal. What is this type? This is not an extensor surface actually. This is the axilla, armpit. So first one. So these are flexural surfaces. So psoriasis can come in flexural surfaces also. Mostly if a skin lesion come to us in flexural surfaces, we usually identify it as fungal infection in moist places where fungus will grow. But in this case, psoriasis, it is psoriasis. Look at the lesion. In fungal infection, there will be central curing. So here there is no such thing. Central curing is not there. The lesion is almost all over that area. This is a flexural psoriasis, also called inverse psoriasis. So pustular psoriasis, a red and scaly thing with tiny pustules. Guttate psoriasis in childhood or young adulthood, small red spots. Usually all follows a streptococcal infection or tonsillitis, like that. Inverse psoriasis is skin lesions in skin folds, armpits growing. It is rare actually. And erythrodermic psoriasis, which causes fiery redness of the skin and shedding of scales in sheets. It is fatal. So these are the types of psoriasis. And what about the comorbidities? Mostly psoriatic arthritis is one of the Upadrava Vyadhi or comorbidity of psoriasis. How can you identify psoriatic arthritis? Only looking at the nails or the hand, you can identify psoriasis. Actually, in examinations and all, we will present a picture like this and ask the students to identify. Looking at the nails and the finger joints, you can identify psoriatic arthritis. The nail will be pitted and the distal interphalangeal joint will be swollen. So psoriatic arthritis is that arthritis where distal interphalangeal joints will be affected. One more arthritis is there where DIPs are affected. Which one is that? One more arthritis other than psoriatic arthritis where DIPs, distal interphalangeal joints are affected. Which one is that? Where Heberden's nodes will be there. Anybody? Heberden's nodes, Bouchard nodes.
Rheumatoid arthritis.
Rheumatoid arthritis always affecting the proximal interphalangeal and the metacarpophalangeal joints. Proximal interphalangeal and metacarpophalangeal. It will not affect the distal interphalangeal joints. DIP, osteoarthritis. Yeah, osteoarthritis is that arthritis where DIPs are affected. Other than that, the other arthritis is psoriatic arthritis where nail changes will also be found. So in your clinical practice, just looking at the nails and hand, you can identify psoriatic arthritis. And what about the signs and all? You all know candle grease sign. Usually we light candles in our home and all. That grease will be spreaded in the floor, and we use to remove that grease, right, with some thick paper or knife and all. So like that, if we can use X-ray film or things like that to remove the scale, the thick scale. If it is removed like a candle grease, then it is called a candle grease sign. That white scales can be scraped off as small flakes like wax from candle. Further scraping removes a coherent moist sheet corresponding to lower level of epidermis, that is called the last cuticle. And on the removal of last cuticle, minute pinpoint bleeding spots are seen. That is called the auspice sign. So these are all you know. Investigation, there is nothing other than the careful case history actually. The golden standard is skin biopsy, but it is not possible to send the patients, all the patients, to skin biopsy and all. Mostly it will be diagnosed from the case history itself. But in suspicious cases, you can use skin biopsy. Ayurvedic correlation, so many people call it Kidibha's plague psoriasis, Kinagara Sparsha and all, and the Sithma's scalp psoriasis, Prayana Urdhva Kayam. But the reject grades things are all happening in Sithma. So we Kerala people always say psoriasis as Sithma only. And guttate psoriasis mostly it is considered as Mandala Gushta, and palmoplantar psoriasis as Vipadika. These are some considerations. We need not go through these to identify a skin disease actually. Only concentrate on dosha sthiti. And the Daudhiga Pushpavat said in Sithma. So Dugdiga is Euphorbia hirta actually. It is almost looking like this, Daudhiga. I don't know whether this Dugdiga Acharya told. In most of the test, it is written as Alabu. Alabu Pushpa is whitish. So silvery white lesions. So this is there in almost all tests. But when we look at the Dugdiga, we find this plant with the flowers. Usually we find in our neighborhood. So it seems like that also. I am actually a little bit confused, but need not worry about all these things. The olden times, there are no videos, pictures, and things like that. So Acharya used to say, resembling some dravya. There is nothing to do with that things. Coming to the treatment, psoriasis is actually a chronic relapsing disease. There is no ultimate cure. So there is a query where psoriasis can be fully cured. So actually, psoriasis is chronic relapsing. So it will be in an on and off fashion. It will come and go. But we can remove all the symptoms. 100% it will be removed. In that sense, we can say that we can cure it 100%. But if the patient go for apatya, as all of you know, nimitte alpepi govana, that is told in Kushta Chikitsa, Kushta Apururupa. So if there is some nimitta, some triggering factor, then it will relapse. So that is the problem with the psoriasis. Even it is most found in those people who are stressed, who are dealing with these financial things and all, the share market things like that. So mostly in stressed persons, the psoriasis is found and it will be relapsing. The choice of therapy for psoriasis is determined by disease severity. How much severe it is, how much dosha bala it is has. Likewise, we choose the therapy, that the treatment. Psoriasis patients are frequently categorized into two groups, mild or moderate to severe psoriasis. So one group is mild or moderate with not that much dosha dushti, and severe psoriasis with dosha prabalatva. So here treatment differs. Basically, one is Shodhana Pradhana and another is Shamana Pradhana. That is the thing. The mild to moderate cases we can treat at home itself. And the severe psoriasis only we have to admit and treat. The score used to assess whether it is mild, moderate, severe is PASI score. Everyone should be aware of this thing. PASI score, PASI tool. It is you can find in the net. PASI score also you can calculate using network. A PASI score is a tool used to measure the severity and extent of psoriasis. It's called psoriasis area and severity index. A PASI score of 5 to 10 is considered moderate disease, and a score over 10 is considered severe. So if it is over 10, you can admit the patient and go for Shodhana Kriya. And if it is 5 to 10, you can treat at home itself. The maximum PASI score is 72. Of course, the treatment principle in Ayurveda is Nidana Parivajana. Nidana is very important in Kushta also. So it is very important to remove all the stress and triggering factors. Then Shodhana and Shamana and Rasayana are the treatment principle. Treatment Bahudosha or severe, Shodhana, Alpadosha, Shamana. And also in Vata, Kritapana is very important. If it is Kapha predominant, Vamana, and Pitta predominant, Virejana. These are the drugs, some of the drugs we are used for Shodhana. Even all the drugs described in Kushta Chikitsa are having Shodhana property in one way or other. Krida, Dendi, Krida, Mahavajra, Krida, these are all having Shodhana property. Kashaya, Padola, Muladi, Kashaya, we are using extensively in our wards. Mandipadra Gulam, even it is a Rasayana, it has got a Shodhana property. Churna, Vipatti, then Madana Phala, Ishtindra are used for Vamana. Bahya Shodhana also, Kshalana, Seka. And Shalana, you have to think of these drugs. If it is Kabha Adikya, with the Scandi using with the thickness, then you use Triphala Tok, Aragoda, and Nimba for Kshalana. If it is Pitta Adikya, if there's erythema or burning sensation, etc., then you can use Nalpamara, Haridra, Nimba Tok, Eshti Madhu. Nimba is both present in both Kapha Pitta Shamana. So this is your choice of selection of drugs. Which drugs are available near you or which drugs are available, then you can choose that drugs. This is for external dhara or shalana. For Abhyanga in Vata Pitta cases only, Jivandyadi, Shadadavada, Krida or Dupavadi Kera. Then Shamana yogas, so many are there. According to availability, you can choose. In Kapha Pradhana, Aragudadigana is better. And in if it is Kapha Pitta, you can choose Padoladhigana or Nishotamadi or Nimbadi or Kolakadikashaya according to the availability. If it is Pitta Kapha, you have to choose Guluchiyadi. And if it is Pitta Vada, Mahatikta Kashaya is there. And Kapha Vada, Gulutikta Kashaya is there. And if it is Vata and Rekta, Vadarekta. Vadarekta means Vada, Pitta and Kapha only. Manjishtadi Kashayam is used for Rukshana. Manjishtadi Kashayam is used for actually Rukshana. Somewhat Rukshana it will give. Shoshana and Rukshana. Manjishtadi. Manjishtadi is preferred by me mostly. Arishta and Asava also we can use in Kapha predominant conditions. Nimbasava, Khadira Arishta, Nimbamradasava. Arishtas actually in psoriasis, I'm not using that much regularly. Gulika, Kaishwara Gulgulu, Vilyadi Gulika, Arogya Vardhani Dushi Vishari. These are all used by most of the physicians. That is why I have written all these things. Khridam, Aragoda Mahatiktagam, Tiktagam, Mahatiktagam. These are the Khridas mostly used. And about Tailam, Toraka Tailam, as all of you have heard, Eladi Keram, Dinesha Valyadi, Nalpamaradi, Turvadi, Jatyadi, Gulgulamarjadi. These are the Tailas which were used very popularly in psoriasis. And about Churna, Shadharna Churna, Bhunimbadi Churna, it is told in Kushta Chikitsa itself. And the third one is very, very important. It was used by our late Rajagopalan sir in most of the cases of psoriasis. It is from his experience I have quoted that. And Dr. Rajagopalan sir, he is late. Most of you may be knowing knowing him. He used Nimbadi Churna in most of the psoriasis cases. It is in Vaishyaratnavali Vadarekta Adhigara. You can quote that from Vaishyaratnavali, Nimbadi Churna. And AAA is for external internal use. Eladi and Nimbadi Churnas are externally used for regaining the color and texture. And coming to Rasayana, Tuvaraga Rasayana is mostly told in Sitma, Bhaladaga in Kushta, but Bhaladaga is not regularly used. Bakuchi in Shutra and Sitma, and Chitraga in Shutra. So Shutra here, I am not commenting on leukoderma and all. If there is discoloration, if the color is not regaining, we can use Chitraga Rasayana. Manipatra Gula also is used popularly. And one thing I used regularly is Gandhaga Rasayana. Gandhaga Rasayana is told in Kushta as well as in Vada Shonida. In tablet form, it is available 1 gram, 2 to 6 months we can use. Only thing is that you have to monitor diabetes and hypertension. There may be fluctuation sometimes. That is the only thing. Gandhaga sulfur is also used by the homeopathy doctors for skin diseases. Madhusnuhi Rasana is used in chronic infective conditions. If infection superimposes in chronic infections. Mulaka the Arishta is on such Arishta, where actually Mulaka is another drug, but Madhusnuhi used this instead of Mulaka. So Mulaka the Arishta can also be used in chronic infective skin diseases. Madhusnuhi Rasana in syphilitic condition, in gonorrhea, also in chronic infective conditions we can use. Coming to the stress factor, we always prescribe Takradhara, Aragodadigana Musta Amalagi. Once in a while, if the patients are doing Takradhara, if they are very much stressed, then the disease frequency will be much less. That is my experience. Kalyanaka and Mahakalyanakrada also can be given in such cases. These are some of the ganas. Kandukna gana, if there is more itching, Kapha Pradhana, any of these drugs can be used. Gana, from the gana, we can choose drugs according to the availability. And Kushtakna gana. So, what are all drugs are available near us, we can have this Kushtakna gana even for preparing water. No, for drinking, actually, we can use these drugs. Siddharthaka Snanachurna is told in our Shastra, it is used for Vamana, Virejana, Utkarshana and Snana. For all these purposes, Siddharthaka Snanachurna can be used. Madana is also present in that, Madana Bhala. So it can induce Vamana also. So this treatment protocol may be adopted. Usually we are following this treatment protocol. The only slide I have to concentrate in the treatment aspect is this one. The condition, look at the condition. If the condition is severe itching, scaling, means it is Utklishta dosha. The step 1, Kapha Pitta or Utklishta. So in Utklishta dosha, there is no need for Snehapana first, because already the doshas are in Utklishta state. You just use Padola Muladi Koda for 6 days. It is a Koda. It will remove the doshas, even from the interstitial spaces and all. So it will clear the srotases. So Padola Muladi Koda for 6 days. External Shalana with Aragoda Digana Churna. The step 2, after appetite Kridapana, Aragoda Mahadikta Krida, Samyak Sniktha. Then Utklishna Ahara, Vamana, if it is Kapha predominant. If it is Pitta predominant, you can directly go for Virejana, that's step 3. And the step 4, if the doshas are less, the lesions will become dry, itching will be reduced, then you can give Abhyanga, even you can use Takradhara for stress, and the Rasayana, Tuvaraga or Gandhaga you can use. And the step 5, Shamana medicines, diet and regime, Manibhadra Gula for 1 month. So this is the thing you can practice in each and every psoriasis patient if the condition is severe, that is the PASI score is above 10. Okay, so this is very simple, you can treat. The second thing is moderate Anutklishta dosha. Don't use Padola Muladi Koda, only use some Rukshana with the Manjishtadi Kaishwara Gulgulu. And if Kapha predominant, then you can have the second step. And if Kapha is mild, you can have the third step, and the fourth step and fifth step as such. In Alpa dosha, you just use Padoladi Ganakashaya or Nishopatamadi Kashaya and Vilvadi Guliga. Araguda Mahatikta Shamana Sneha only, no Shodhana needed. Intermediate Virejana with the Manibhadragula. Once in 15 days you can use Manibhadragula after using this Krida and all. And Abhyanga and Shamana drugs. This is necessary, you can be treated at home. So this is the protocol we can adopt. As per my experience, over more than 500 patients, we can use this as a protocol. Okay. A little bit focus on Nidana also should be there. If stress is the main problem, you just concentrate more on Takradhara, Mahakalyanaka for Snehapana. If infections are more, is the triggering factor. If after some infection, streptococcal infection or some other things, if it is happening, then you just concentrate on Guluji Adikashaya, Guluji Sattva Amrtotra Kashaya, Madhusnuhi, Kaishwara Gulgulu, Tiktagrada, like that. And if medications are the triggering factor, Doshi Visha concept will be there. Vilvadi Guliga, Doshi Visha Guliga. Vilvadi Guliga is for acute toxicity, as it is said in Sarpa Visha and all. So medications can trigger skin diseases. If that is the condition, you can directly use Vilvadi Guliga. And Doshi Vishari is for latent toxicity. It is like Doshi Visha. So for acute toxicity, we can have to use Doshi Vishari. But for latent toxicity, we can use Doshi Vishari Guliga. And Padoladi Kashaya will be the choice. So this is a little bit focus on the Nidana part. And in psoriatic arthritis, the approach will be Vadarekta treatment. Manjishtadi Kashaya, usually I follow this regime. Manjishtadi Kashaya Kaishwara Gulgulu, Dhara with Dashamula and Karaskara. It will give a tremendous result within 10 to 14 days. And later on, Snehapana, Araguda Mahatiktaga or Vajraka Krida you can use. Then Shodhana with Manipatra here. Then follow with Rasayana, Gandhaga Rasayana and Madhusnuhi Rasayana can be used. Then Shamana, Rasnaranda Kashaya with Kshirabala Taila or Shira Guluji, or even Gulgulu Tikta Kashaya can be used in some cases. And Abhinga with the Pinda Taila or Vitpala Taila. This is the treatment protocol usually followed in psoriatic arthritis. And a little bit comment on Aditya Paga Taila. So the role of skin, the role of sun. Vitpala Taila and Gulgulu Marja, there are two Tailas. Which is said to be having this sun exposure. UVB exposure from the sun can slow the rapid growth of skin cells in the area. So ultraviolet B exposure from the sun can slow the rapid growth of skin cells that occurs in the psoriasis. It will reduce scaling. That is why you apply Thaila and expose the patient to sunlight. In some local Vaidyas or ashram, sun therapy is also followed in psoriasis. So this is the principle. You know the Vidpala, Rhytia tinctoria, the leaves in coconut oil. You all know the procedure. Now the PUVA thing, PUVA is an acronym. P stands for psoralen, U stands for ultra, V for violet, and A for the portion of the solar spectrum between 320 and 400 nanometers. The PUVA therapy is used in psoriasis as well as in leukoderma. So psoranil will be given internally and they will be exposed to ultraviolet light. That is the treatment. Baguchi is having psoralen, Psoralia coralifolia. So Baguchi rasayana is also can be adopted in psoriasis as well as Shutra. Now about diet. Diet is very important. Fasting periods, low energy diets and vegetarian diets improve psoriasis. These are from studies. So we also ask the patient to stick on vegetarian diets, and yoga and sadvrata also, it is not diet actually. Masha, tila, didi, guda, mamsa, pickles, fried items, fast food, sour and salty. These should be avoided. And the habits, addictions also should be avoided. Stress also should be avoided. These are the things to avoid. The diet and the factors, these are having very much important in preventing the recurrence of the disease. Now coming to the last part of the presentation, the case study. This is why I am presenting this case is that this is the this is actually the case. I have lost my 4 days sleep actually following this case. So that is why I am presenting the case. A patient with a history of type 2 diabetes, dyslipidemia, hypertension. So all the comorbidities are there. And coronary artery disease, CAD, heart disease is also there. He developed reddish elevated skin lesions 4 years back as an acute onset. He went to allopathic doctor, prescribed an ointment, and the lesion subsided. So he was happy. After 2 months, the lesions reappeared and spreaded over the trunk and limbs. So he was worried. The lesions were bigger in size, and itching and peeling of skin was also noted. He was continuing allopathic treatment at that time, but he discontinued and just go to a homeopathic doctor and getting treatment from there for about 1 year. So by that time, tiny pustules developed on the border. So that means it became pustular psoriasis. With no apparent relief, he consulted another dermatologist. He returned to modern medicine, and complete relief was there within 2 months. He was continuing the medicines. There was no problem for the next 6 months. But again, the symptoms appeared and become very much severe. And in March 2021, he got vaccinated for COVID-19. And immediately after that, the symptoms became very much severe. So the medication, the vaccination acts as a triggering factor. It triggered the psoriasis. The condition was so severe that reddish lesions with itching spread all over the body, and with the tiny papular lesions with itching all over the body. Fever was also present. He took allopathic treatment for 2 months with antibiotics and all, but he was not getting relief. He stopped all medicines except for diabetes, hypertension, dyslipidemia, and CAD, and came to our hospital on 28/6/2021. So this was the condition. Actually, he was admitted in 28, but we took the photographs only on July 3rd, after 5 days actually. So on July 3, this was the condition. The first exfoliation all over the body, the truncal area, small, the third picture, small pustules are seen. You cannot see the pustules, but there are small pustules. And the fourth one, the legs, full erythematous lesions with the extensive peeling of skin. So this is the condition of the patient with the PASI score around 39 or 40. So generalized pustular psoriasis presents with an acute and rapidly progressive course, characterized by diffuse redness and subcorneal pustules. Subcorneal means the outermost corneal layer, avabhasini, sigma, and is often accompanied by systemic symptoms. Here, fever is a systemic symptom actually. Now, what was the treatment done for the first 7 days is the lakshanas were pitta, erythema was there, pustules was there, mild fever was there. In kapha, itching was there, vata, scaling and spreading all over the body was there. So both, all the three doshas are there. But the patient bala, agni bala was pravara and deha bala was madhyama. Dosha avastha, why deha bala madhyama means he is a patient of CAD, that is why I wrote as madhyama. Actually he was doing all the activities and all. Dosha avastha here is utklishta dosha avastha, pitta kapha predominance. And Shodhana, I done for Padola Muladi Virajana for 2 days. Padola Muladi as indication of fever also. So Padola Muladi Virajana for 2 days I have done. And then followed with the Shamana, Manjushtadi and Kaishwara Gulgulu tablet. Kshalana with the Dashamula, Karaskara and Nalpamara. So this is the treatment done for the first 7 days. And the next stage, 8 to 13 days, the erythema thing was reduced. Pustules still present with mild fever. Kapha itching was reduced. Vada scaling was there. Agni bala and Deha bala are okay. Dosha avastha still utklishta but pitta predominant. Then I changed the Shodhana to Avipatti Churna in Drakshadikashaya. Why? Because I was considering the pitta. Tikta Madhura rasas are important for pitta. Tikta Madhura. So Tikta Madhura Shodhana is Avipatti Churna. 10 grams in Drakshadikashaya for 3 days. And Avipatti Churna in Padoladi Kashaya for the next 3 days. So first in Drakshadi Kashaya for 3 days and next in Padoladi Kashaya for 3 days. After the Shamana, Villuadi Guliga, Sudarshanam and Gopi Chandana tablet, because fever was there. Villuadi, Sudarshanam and Shamana, Gopi Chandana was also given. Actually, I lost my sleep for 4 days in this period because he was feverish. Erythema was there in the body. Pustular psoriasis is there. He will be very much in a condition, fatal condition. But the patient, actually I advised him to get allopathic treatment, but he was not willing. He was saying that I am under allopathic treatment for a long period. I was not getting any relief. I want relief from here. I will not go. So I took a written consent from the patient and the bystander that anything happens, it is not our fault. We have advised things properly like that. So after that only I gave the medicines. But actually I lost the sleep because anything can happen to the patient. Another patient was there from Orissa previously when I was studying there. The doctor who is treating, I am not revealing his name and all, but the patient died when I was studying Kaijigilsa. So that thing was in my mind. So I have little bit fear also in dealing the case. Anyway, I got the consent of the patient and the patient is not willing to go. So I started the medicines. Avipatti Churna and Drakshadikasha. I am so fortunate that the fever actually reduced within 5 days. So thank God for that. And in July 14, this was the condition. The pustules, the erythema, things were gone and the scaling persist. And for that, I used Shamana, Mahatikta Ghrada and Vilvadi Guliga and Shuddha Druvadi Kera for Abhyanga. Takradara for head was the next treatment. He was stressed actually, the patient. And at the time of discharge, July 19th, this was the condition of the patient. Not much of scaling. The scaling has reduced by oil application and all. But now you think that the case end here, but the twist is, and how it is going to come. The actual twist of the case is yet to come. He was discharged on 19 and advised Mahatikta Grada 10 gram morning, Gandhaka Rasana as Rasana 101, and Shuddha Durvadi for Abhyanga, Manibhadra Gula once in 15 days. So this was my advice on discharge. And July 19, he discharged. But he had a follow-up on September 10. After 2 months, had a follow-up. Now look at the lesions. New lesions has come. All the pustules, all the scaling has gone. And now the classical feature of plaque psoriasis. This is the same patient. The classical feature of plaque psoriasis emerged. But he was happy because lesions are not so severe. He can do all the daily activities, but I was surprised that it has gone through the pustular psoriasis, and then now the plague psoriasis set in. Now the treatment, erythema is mild, itching, plagues are there, scaling is there, Utklishta kapha pitta doshas are there. Now I gave Padolamuladi. There is no need of admission and all. It is not severe, so severe. So Padolamuladi was given for 6 days at home itself. And after that, Manjishtadi, Kaishara, and Vilwadi Guliga for 10 days. Followed with Araguda Mahatikta Ghrada 10 days for 15 days. 10 grams for 15 days. And Dhara with Araguda Diganakashaya. So these are the medicines given. And now the next month, 1 month after, this is the condition. The plaques were reduced, the lesions were reduced, the numbers were reduced, and the patient is feeling much satisfied. October 14. And the next treatment, only there is some lesion. So Manibhadra Gula once in 15 days. Arakuda Mahatikta and Gandhagrasana has to be continued. And Vitpala Taila and Shuddha Durvadi Kera for Abhyanga. So that was given. And after in November 18, 2021, the case was like this. Only 1 or 2 lesions are left in the low back, and still he's having some medicines, actually in the form of Vilwadi Gulika and all. So this is the case. This is under follow-up. He used to call me once in a while. Now he is free of symptoms and all. So why the case presented? Because all the form of psoriasis, pustular psoriasis, erythroderma, or even plague psoriasis, you can find in the same patient. Because in psoriasis, the morphology, the lesions will change intermittently. All types of morphological change can be visible, but not in other forms of skin disease. So thank you for listening. I emphasize the importance of Deva Vabhasara Chikitsa also in Shiva Sutatara Bhaskara Aradhana, that is told in our Shastra to relieve the stress, and all stress is a triggering factor of psoriasis. So to relieve from stress is very important, to keep our mind engaged in good things, good thoughts, and also Deva Chinta is also good in preventing psoriasis and all. So thank you. Now it is query sessions. You can ask the queries. Hello.
Hello, sir. So we'll give the delegates some time to shoot their doubts if they have any.
Sure. You can have so many doubts actually treating psoriasis. Independently, if you start treating, the more doubts will come. Use of Sadhya Vamana in psoriasis. So actually, in my practice, I performed Vamana in only 1/4, less than 1/4 of the cases. Why? Because this disease, I told, it is inflammatory. And the seat of the disease actually is in Rekta Dhatu. So in Rekta Dhatu, the treatment mostly focuses on Virejana and Rekta Moksha only. So it is spreaded all over the body, mostly in many cases. And Vamana is only given for such patients who are below 40 years of age and in Vasanta Ritu. and if having kapha predominance. So that is why in most of the cases there is no need for vamana and all. In high severe cases only I prescribe vamana. Otherwise, there is no need for vamana. With virajana itself, with virajana and rasayana itself, you will get the result. Concentrating on the dhatu, the seat as rekta. And about sadhya vamana, if there is that much need of expelling kapha, also if it is vasanta ritu, then we can have sadhya vamana if he is aversion for ghee and all. Krida, some people have got aversion for krida sneha and all. So in that patients we can use sadhya vamana. But actually there is no need of sadhya vamana. If you perform vamana, then you have to give shodhananga snehapana and then perform the vamana. That will be better. I'm not saying that vamana is not useful, but you have to be careful. Precaution should be taken if you are advising vamana in patients. We have performed an n number of vamanas in patients with the psoriasis. But we are getting results even if we are not performing vamana in patients. Also, we are getting results. But in kapha pradhana, if it is kapha pradhana, kapha predominant, then definitely you have to go for vamana with respect to the ritu and the bela of the patient. And in yavana avastha, it is very much needed. So that is my perspective on vamana. And the second question, can anybody read that question? The second one. I'm not seeing the chat
Yes,
box
sir.
here.
Sir, thyroid is said to be abatya in kushta. So, does there is any chance for flare up when we give Shirabala along with Rasnerandadi as Shamana, as you said in psoriatic arthritis?
Okay. Thyla, which that thyla comes under monounsaturated fatty acids will be a triggering factor for psoriasis. But when you come to Kshirabala, if you closely look at the preparation of Kshirabala, you know that it is processed in Kshira, and most of the lipids come from the Kshira is Krida based only. So I never felt or I never experienced such a result from any of the patients given Shirabala or even Shiraguluji. That will act as anti-inflammatory only, will not trigger. So Shirabala Thaila is explained in Vata Rekta itself, where Rekta is the Dhatu affected, and it will not cause any flare-up. That is my experience. And also in Shirabala, important Thaila, more important, we used to think of Grada instead of Thaila. When you prepare Shirabala, Avarti and all, the last thing we will get only the Grada part will be more. Thaila part will be less. So Shirabala as such will not cause vitiation of Rakta Dhatu. Any other queries? Even we can do Vasti in psoriatic arthritis patients. Yapana Vastis are performed in psoriasis. Because it is said that even if Vasti is contraindicated in Kushta, Avastam Prapya Nirdishtam Kushtinam Vastikarma, it is told. So if it is that Avastha where Vata is predominant, affecting the Sandhis and all, you can perform Vastis also. Kshiravasti, Panchatikta Kshiravasti, or Yapanavasti, like that.
Sir, there is one more doubt.
What will be the Avastha of Takradhara, right? On the body, Takradhara. Takradhara actually, one of the studies says that it is just a simile of yoga. Yoga chitta vritti nirodha, no? First, it's a stress reliever. So if you are doing Takradara, the stress factors will be relieved. What is the exact mechanism of that? I don't know. Two things I know is that one, it increases the serotonin secretion. Second one, melatonin secretion, like that. So what is the ultimate effect? I don't know, but it will after Takradara, the patient will get good sleep and all. The mental worries will be that much reduced. They will be free from stress and all. So the stress is a triggering factor for psoriasis. So for stress-related conditions, we use Takradara. And what avastha the body is going through, actually, I don't know. Maybe Vata is stabilized because Shiras is the Asrasthana of Prana Vata, Vata and all. So Shiras, Indriyas, and the Vata Pravarti will be stabilized by Takradara. That only I know. The studies say that Takradara has equal effect like yoga. If yoga is Chitta Vritti Nirodha, Takradara is also that much beneficial to mind and stress. Any more query? And in Takradara, we use Aragudadi Churna also. Musta, Amalagi, Aragudadi Churna for Takradara. If skin lesions are present. The problem with Takradara is that if we prescribe Takradara, they will do the entire body. There is no need to do entire body Takradara. Only to the head, it will give the optimum result. Takradara to the body, I don't know how much result we will get. Dhanyamla is Sparsha Shida, but Kaphavada Shamana Ushna. Dhanyamla, I don't think Dhanyamla is a pure drug of choice in Rektadushti because it is Kaphavada Shamana. So in Rekta, Adhisthana, Pitta, predominant disease like this, I don't think Dhanyamala is a good choice. And about Nasya we will perform in scalp psoriasis. And we used to give Nasya in scalp psoriasis. That also the Thaila is more often in the form of Kalka, Kalka Nasyas that we will use in scalp psoriasis. And the Rekta Moksha, we often didn't perform Rekta Moksha because the pathology is a little bit inflammatory. We're giving vasodilation, dilatory things and all. So Rekta Moksha will definitely increase Vata, the scaling if it is present. We cannot increase Vata in the superficial layers and all. So Rekta Moksha we often are not giving, but anywhere if it is given, I don't know. But Rekta Moksha, Shat Masa, in every 6 months we can perform Rekta Moksha in Kushta Chikitsa, as per Kushta Chikitsa, but I am not experienced on that and I have not performed it and not even seen Rekta Moksha. That much, it is not popular actually. We can do, but only one thing is that Nasya Deha Prabhanjana. We have to protect the body from Vata. So Vata is the culprit. So we have to protect always Vata. That is why we used to give Sneha and all always in between Shodhana. Rekta Moksha, if that much aggravation is there, then we can give. But I am not experienced. Okay, I am not the person to comment on Rekta Moksha because I have not did that Rekta Moksha. Nasya is very much useful in scalp psoriasis.
So there's a query from Dr. Lal Krishna. Use of dhuba in any stage can be used or not?
Dhupana. Dhupa.
Dhuba, I guess, sir. Dhuba.
Dhupa is for in bacterial infections. If superimposes, dhupa can be used. The gulgulu or Vranahara drugs. So dhupana is beneficial to avoid secondary bacterial infections. But in regular cases of psoriasis and all, dhupana, I never seen dhupana. There is no need actually. So if you are suspecting some bacterial infections or in superimposing, then only you can use dhupana and all.
So the next query is, please explain Pakshat Chardanath sloga told in Ashtanga.
Pakshat Chardana is based on the dosha predominance actually. In kapha predominance, you have to use Vamana. So the choice of Shodhana will be Vamana alone. You have to do Vamana in every Paksha. That is where even Sadhya Vamana we can apply. In Kapha Pradhana Kushtarogas, not in psoriasis actually. Psoriasis is almost Pitta, Kapha, Vata predominant. So there is Tridosha, but Pitta, Kapha will be more predominant. And if it is Pitta predominant, you can choose Virejana. And every month you can do Virejana. So you prepare the body with the Sneha. If Snehanga Shodhana is needed, Snehapana, then give Shodhana each and every month. And if it is only in your Urdhvanga, then you can choose Nasya for each every 3 days. You can do Nasya until the lesion subsides. And Rektamosha, if whole body is affected, you can prepare the body. You can choose Rektamosha every 6 months. In between, you can do even Vamana or Virejana according to the dosha. But the whole body is affected, you can choose Rektamosha. So all the 4 treatments are not needed for each and every patient. The treatment which is confined to that dosha, that only you have to give. And here, if Pitta is predominant and Rekta is the sthana, you can choose Virejana. Virejana is having that much importance. So that is why almost all yogas prescribed in Kushta Chikitsa is having Virejana guna. Atakaya Shodhana, even if it is Padola Mula, even if it is Tikta Krida, Vajra Krida, or any medicines, even is Manipatrikula, everything is Virejana. So Virechana is having that much importance because Rekta is the Adhisthana. And the Pitta skin is also Pitta Sthana. So Sthana, Dosha, everything is in favor of Virejana. That is why we focus more on Virejana rather than other treatments. Any other queries? So in psoriasis, as you know, you can see the hard scaly plaques in the superficial area. We definitely think of Vata and Kapha, but when we remove that plaques, you know, you can see the red spots. Actually, the Pitta there. So Pitta is underlying. So we cannot forget Pitta. So always Vata Kapha didn't work. Consider Pitta also.
Yes, sir. I think the doubts are finished.
Okay. So before everyone leave, we will wind up the session, okay?
Yes, sir. Sir, I would like to call upon Dr. Sri Lakshmi for rendering the vote of thanks.
Good evening to one and all present here. It is such an honor for me to have the opportunity to thank you all the dignitaries. On behalf of HSA 2122, I would like to express my gratitude to all the esteemed delegates for their presence and contribution to make this webinar a great success. I extend my gratitude to our Honorable Chief Guest, Dr. Pravith Sir, Associate Professor, Department of Kaya Chikitsa, Government Ayurveda College, Trivandrum, for taking out time from his busy schedule to grace the event. Thank you, sir, for inspiring and encouraging us with your extensive knowledge. A special thanks to Dr. J. Ma'am, Principal, Government Ayurveda College, Trivandrum, for providing immense support to make the webinar happen. I must thank the organizing team of VEEKSHA Academic Series for their sincere effort in conducting a series that will deepen our clinical knowledge. Thanking all the attendees of the meeting for their active participation. Thank you everyone once again for making the 6th session of VEEKSHA Academic Series a great